will go up in the new year. So thank you all again for coming along. We've got a really great range of speakers today. For those of you who don't know me, my name is Zoe Hughes. I'm the Senior Policy and Research Officer with Care Alliance Ireland. And I'm going to hand you over now. I'm going to be speaking a little bit later, but I'm going to hand you over now to Carmen Elise Pocknell, who is a member of our board of directors. She is also a member of our subcommittee for research in Care Alliance Ireland, and she's going to be chairing the day, keeping us to time, keeping us on track, and managing any questions and things like that that come in the chat as the speakers are speaking. So, Carmen, over to you.
Thanks, Zoe. Thanks for the great presentation. Welcome, everyone. I can see the numbers go up there, so you might leave a few minutes just for everyone to log in. We were saying at lunchtime, it always happens where people, get that rush and realize it's 2 o'clock already. So we'll leave those 5 minutes there. Just to introduce myself quickly, so Zoe did a great job. It's just because you'll hear me for the next 2 hours coordinating this talk. So my name is Carmen Elise Pocknell. I joined Care Alliance Ireland as part of the research subcommittee, like Zoe said, in April. So very new, but I've also heard a lot about Care Alliance Ireland in my research work. So I'm a researcher by background. I do a lot of work in palliative care and helping caregivers as part of the training for end-of-life care for advanced dementia. So that's really the interest I have next to this board. And then I work, with the board closely with all the next missions we have. So it's really nice to meet you all. I hope to get to know you through the session today as well. We have a large range of topics coming up in front of us there. So we'll try and stick on the time. We'll make sure, to not go over because they're very, very interesting, very new as well, very innovative. So it'll be, there'll be a lot of inspiration, I think, coming out of these talks coming out. And we hope so anyway. And Zoe and Yam and Amy have been working hardly for that. So I'll introduce you to our great speakers in a few. I'll probably wait 2 more minutes. Is that okay? And then I'll come back to you. We'll probably start like at 7 or 8 past, something like that.
I think we're probably okay. I think we can keep going. Rather than when you said dead
Okay.
air, you're just like, we all just
Yeah.
look at the little black boxes with everybody's name in it. But I think we'll just keep going. I think that's no harm.
Okay.
If that's okay,
Yeah.
Carmen. Super.
Yeah, that's fine, definitely. So again, we are online, so there is that specific setting. But if anyone has any questions at the end, we will have 5 minutes for it. The first one that's going to come up is going to be a pre-record session. So it's going to be our very own Chief Executive Officer, Liam O'Sullivan from Care Alliance Ireland, who pre-recorded a lovely session around the history of, the National Carer Strategy. So he kindly did it with his own time. Unfortunately, he sends his apologies. He had a defined commitment, so he couldn't attend. But yeah, it's kind of a good one to start off with. There's a lot going on, in the caregivers world, so it really just gives that start piece to the session. So we'll put that session on. I'll, take a seat, kind of immerse yourself into the topics today with it, and I'll be back in 15 minutes after this session. Hopefully it works well. If you don't mind putting it on, Amy, thank you. Amazing. We can.
Hello, everyone, and welcome to this research seminar. Delighted to see you've all registered and have taken the time to join us this afternoon for, I think, what promises to be a interesting and varied exploration of some of the maybe more under-discussed topics in the context of family care. Unfortunately, I'm not available to be here in real time, unfortunately, due to a last-minute call to something else. So I do apologize for that. Zoe's asked me to say a little bit about, I suppose, around the background to the National Care Strategy. I've been around and in this role for quite many years. So although my memory may be a little bit hazy, I'll endeavour to try and say a little bit about my thoughts and experience of the process of the last National Care Strategy back in 2009, 10, 11, and as I recall, its eventual publication in 2012. And I'll also say a little bit about, I suppose, where I think the strategy is now. We've done some work with our colleagues in UCC, Maria Pierce, on that. And I suppose also I continue to be of the belief that a new family carer strategy is in the best interest of progressing the situation of family carers and organizations who support them. So I didn't start Googling or searching back my emails from 2008-9, but from memory, I know it had been I suppose, a an ask, a call, as it were, from across the kind of family care sector, being led largely by Family Cares Ireland, but indeed by other organisations, including Care Alliance. And I suppose we were always of the view that putting together a document would bring impetus and help move forward a whole sorts of aspects of family carers' lives. So I have a vivid recollection in 2009 and being on a bus coming home, and it was announced that the commitment to developing a national care strategy was to be, in a sense, gotten rid of. I think it was in the context of the economic crash, and I think the government decided we're not going to pretend we're going to commit to it. So to be fair, fast forward to I think 2011-12, we began meeting a number of organisations, again led by a very capable John Dunn in Family Cares Ireland, and we, I suppose, spent a number of meetings teasing out what would be important um, things that we could seek delivery on to improve the situation for family carers across Ireland. It was in the context of, I suppose, a growing evidence base, growing numbers of data around family carers, and indeed greater public attention around the situation of family carers. I also remember feeding into various drafts that the Department of Health worked on. I think credit to Sinead Quill, if I recall, in the Department of Health, who eventually who was perhaps charged with getting it over the line. Again, I remember receiving a call, I think it was in the summer perhaps of 2011 or 2012. I think I dropped my kids to a cool camp or something like that, and I was in the car and I took a call from Sinead, and I think it was really a heads up to say it's there or thereabouts, nearly over the line. And soon thereafter, to be fair, the government did publish it. We met in government buildings with the then Taoiseach and one or two of his advisors. I think he made a point of making sure he knew our names, not that I'd met him before, but however, it was good to get it signed off, get it approved. I do recall we were slightly disappointed with some of the contents around maybe particular firm commitments. So there was a discussion about the carer strategy being kind of cost neutral. Others perhaps who may be taking part in today's seminar may have a different recollection of that particular issue. But I do recall there was some concern around resourcing not being put in to the strategy at the time. And I think perhaps the government's thoughts were, look, we'll get you a strategy, but we're not going to commit to throwing loads of money or investing loads of money into it. So arguably it was better than having no strategy at all. And then I think soon thereafter, again led by Family Cares Ireland, there was a process of looking kind of like an annual scorecard. Just to be clear, the strategy did identify which departments had responsibility in various aspects, and that was useful. In some cases, it was a number of departments. In some cases, it was the HSE and other departments. But I think that process was very interesting. We really dug in over a number of years. We dug into which aspects had progressed, which hadn't. And if I recall, again, the idea of having kind of a traffic light system in terms of scoring, it was regressive, progressive, no change. And I know Family Cares Ireland led on that for a number of years thereafter. And I suppose that was a useful, in my perspective, a useful way of keeping the government to account. And I looked at some of the figures quite recently around income supports, and I suppose although the National Care Strategy at the time was described as being cost neutral, to be fair, over this period of time, the income, I suppose the financial supports to family carers have increased significantly in both nominal and real terms. Clearly, there's a lot more people identifying as carers, there's more older people, more people with additional needs. So it's a number of things coming together, but from memory, the direct financial support to family carers, depending on how you measure it, of course, but it's in the region or approaching 2 billion for this year and into next year. So I think we do need to acknowledge that more resourcing has gone in that space. Arguably, there's been less additional resourcing in the area of direct carer support interventions, although again, with the development of the Carers Guarantee, there's been some progress in that regard. And then I suppose the ongoing challenges around assessments of need and timely access to therapies remains problematic, as people will hear and know. In terms of home care support, again, I'm a bit of a quant geek, and I suppose I have looked at the figures, and whereas the number of home care hours has increased over the years. It's probably just about kept pace with the aging population. And again, the average number of hours provided in home care has risen perhaps from about 6 hours per client to perhaps about 7, again, depending on how you measure it. And I think the HSE and indeed us all have work to do around more accurately capturing the kind of the quantum of home care delivered. And I'm currently, I suppose, liaising with some officials in the HSE to try and get more accurate data in that regard. Some of the disparities are that in the hours that are contracted out to the HSE, they only invoice, so the for-profit and indeed the not-for-profit providers, they can only invoice for hours delivered, whereas within the HSE delivered and employed home care system, the reporting on home care hours delivered seems to be somewhat off, to be frank. So we look forward to that improving in time. And I know there's talk about using population health data to inform resource allocation. I know there's been some work around the inter home care assessment, again, which is a really good thing, but I also know that the feedback around the pilots is that perhaps it's slightly too long. So some of these things are never panaceas, but again, the right to, I suppose, an assessment of someone's own needs is really important. The right to timely, accessible home care is really important, and hopefully we're getting there around the statutory provision and entitlement to home care, which should move the dial. To be fair, again, the government, a lot more resources in home care, but the kind of costs are provided have really increased. And we know we want people to be paid properly for providing home care. We value care wherever it's provided. So there's some challenges, I suppose, in increasing the overall delivery of home care. I think we may approach 24 million hours in the coming year, which is pretty good. But again, we think more work needs to be done in regard to the kind of shifting the dial in terms of making home care a more attractive proposition for staff, but also for families rather than the default of nursing home care. So in terms of current status, I suppose as the years progressed, we became slightly impatient with the lack of a new care strategy or even a review thereof. So in 2021, we contracted with Maria Pierce and UCC to look at the issues of affecting carers. Where was the strategy relevant? Were the questions relevant? Where were we at in it? And we got some useful information. How that was utilised, it's hard to know. I think it was the right thing to do at the time. I don't think it delayed the progression of a new strategy. Clearly, we're looking for that and have secured that in the latest pre-election commitments, and we hope the programme for government will ensure that. Well, we want to make sure a new strategy is in the programme for government, and we're somewhat confident, but let's see how that pans out over the coming weeks. So look, there's some of my musings, observations. Welcome again. Hope you enjoy the afternoon. Want to thank Zoe and Amy and the team for making this happen. Thank you in particular to the speakers who've committed to sharing their insights and thoughts, and look forward to the afternoon being a challenging but interesting and thought-provoking contribution. And we look forward to working with you all in the future through the Family Care Research Group that Zoe so professionally and expertisely manages, and also in any other opportunities we have to work with you. We've got a budget approved for 2025. We're really excited about the increased resourcing we've been given through the Carers Guarantee to enhance the online care support intervention that Tara and our small team have been managing. And also, literally in the last few days, we got word from the Dormant Accounts Funds that we will continue to deliver an return to employment project into 2025 and 2026. So they're two specific offerings that we're delivering to family carers across Ireland, and look forward to working more intensively with our member organisations. 12 organisations joined our alliance this year. So we look forward to, I'm going to make it my business to meet as many of them as I can in the coming months, and also to continue to collaborate with all sorts of organisations into the future. So thanks again. Bye-bye.
Okay, so thank you so much, Amy, for sharing the video. So again, it's really unfortunate to not have Liam here because I'm sure there's a lot of ideas that come up after this talk. So well done, Liam, if you listen to us anyway, to condense such a topic in 10 minutes. So really interesting to see where we started from and where we are today. One thing that stands out, and I suppose it will give continuity to our next talk here, is the numbers. So there is a raise on the recent report there. I think it was 14% of family carers over 15, an increase of 14%, sorry, of the whole population that are family carers over 15 years old, which is quite a big number. But again, is that related to, that increase of life expectancy, and are we fully capturing with our assessment there? And that's another issue that in so many domains as well, because I'm in research, so you can imagine the tools we use are just not adapted sometimes to this type of, data we're trying to collect in the most accurate way. So a lot of points of reflections there on what we're talking about with these strategies too, and how to encapsulate it in our best way possible. So I like the way, it was nicely framed just to start off. I know that this issue will come out probably quite a lot on different topics. So we'll go on to the next speaker. So we have our very own Zoe Hughes, who is the Senior Policy and Research Officer of Kerry Ireland. So I think I don't really need to introduce Zoe fully. You probably do know her personally, professionally. She is, very present in the caregivers domain. But she will explore today the themes of intersectionality and diversity in family caregiving. So I'll leave you enjoy Zoe's talk, who is always very dynamic. And yeah, I'll meet you in 15 to 20 minutes maximum, Zoe, for some questions. Over to you.
Great. Yes. Oh gosh, the pressure now to be super dynamic in this is it's going to be a lot. But I'll do my best. Thank you very much. So for those of you who know me, I'm Zoe Hughes. I'm the Senior Policy and Research Officer here in Kerry, Ireland, but I am also a doctoral student in UCC, and I'm kind of combining those two, I guess, roles that I have, intersecting them. No. As I'm going to talk today about intersectionality and diversity in family care. And that's really where I'm coming from. So I'm going to do my best to talk a little bit about each of those things and then try and relate it back to the next carer strategy and to policy moving forward, and why it's important to take an intersectional lens to this, but also then to just really concentrate on including diversity within that strategy. So I suppose I just wanted to start off a little bit about some of the assumptions that people make. When you think of a family carer in Ireland, if you're asked to picture a family carer in Ireland, you probably picture somebody who is probably female, probably white, probably Irish, probably middle-aged, probably Catholic, probably straight, and probably cisgender. And for those of you who don't know, the word cisgender just means that you identify with the gender that you were assigned at birth. So for example, if your birth certificate says female, you've grown up as a woman and you feel that that suits you perfectly. So that's what cisgender means, just to clarify that. So those are the kind of assumptions that we often make. And on pure numbers, that is the case. You are most likely, if you're a family carer, you're more likely to be in those brackets than you are other ones. But that's not the entire story. But what I just wanted to show, which I thought was very interesting, and it kind of illustrates a little bit about these assumptions and what it can do to how we think about caring, is AI is a bit scary. It's a bit of a frightening tool sometimes. At least I find it a little bit scary and a bit intimidating, just because I feel there's dangers there to using AI too much. However, it's an interesting tool to use. And what I did was I asked to be AI generated images of an Irish family carers in Ireland. And what AI then does is it scrapes all the information that's basically we give it on the internet, the way we describe caring in Ireland, and it creates an image. And these are the images that it created of family carers in Ireland. Now, I don't know about you, but first of all, they look very, very downtrodden. It looks like something out of famine times, if you ask me. Very, very white, very, very middle-aged, and very, very depressed, and very, very negative. There's also some strange things with the fingers, but I think that's more of a general product of AI than of the information we give it on family caregiving. But I just wanted to show you that if you think about caring in Ireland, you probably think of somebody who looks like that, but that just isn't the case. And we're going to talk a little bit about why and what it means. So if you look at the definition of the census, again, most people on this call will be very well aware of this definition that's used in the census. Provides a regular, unpaid personal help or support to a family member, neighbour or friend with a long-term illness, health issue or an issue related to old age or disability. Now, nothing, that's kind of the definition we work off of in policy in Ireland, and nothing in that really specifies a race, a religion, or sexuality or any other kind of minority status. So included within that definition are all of these people, are all of these minority groups, but are they reflected in the policy that actually shapes how the services are created and how they're actually brought to people? And I would argue no. Which basically just means there's a big list here on the screen. Family carers can be gay, straight, bisexual, queer, cisgender, transgender, Catholic, Protestant, Jewish, Buddhist, however many other religions, young or old, highly educated or early school leavers, because really, as we all know, caring doesn't necessarily stop at a boundary of your identity. And so family carers can literally be anybody. But does our policy really reflect that? So this is an illustration that I found to talk about what intersectionality is. And I'm very passionate about intersectionality, so I could talk for like an hour about this. I promise you I won't, because I will get cut off, and rightly so. However, I just wanted to kind of show you what the kind of the definition of it is, which was put forth by Kimberly Crenshaw like in the late 80s, early 90s. Intersectionality is a lens through which you see where power comes and collides, where it collects and intersects. It is the acknowledgement that everyone has their own unique experiences of discrimination and privilege. And so there's a big list there on the right hand side of these different types of identities that can lock and make things more challenging for people. And that includes race, ethnicity, gender identity, class, language, religion, ability, sexuality, mental health, age, education, attractiveness, and many more. And I would put caring status in that as well as something that can create more of a challenge if you're part of that minority group, because family carers essentially are a minority group, not an ethnic minority group, but they are a minority group within Ireland. And here's a quote from Audre Lorde, which I really, really love, which I think sums it up very, very nicely. There is no such thing as a single issue struggle because we do not live single issue lives. And really, what that is encapsulating is yes, you can be a family carer, but you may also be disabled. You may also be Black. You may also be part of the LGBTQ community. You may also be a woman. You may also be a man. And so there is no such thing as a carer. There are multiplicities of caring, and we have to take acknowledgement of that from a policy perspective. By the way, as I'm going along, we'll have some time for questions, I know, at the end of each session. So do pop your questions in the chat. That would be really, really great. So some of the impacts of caring, again, I'm not going to go into huge detail here because I think most people who are on this call will be well aware of the research and the impacts of caring on individuals. But I'm going to just pull out a few and then come back to them and repeat it later in a different way, just to highlight what I'm talking about. So from a mental health perspective, if you're a family carer, you have a 38% higher chance of experiencing poor mental health than the general population. And then 71% of carers feel left out of society. Now, I really should have put all of the references for all of these in this. I probably will include them at a later stage. I know a lot of the data, the most recent data that I'm using around Irish family carers and wellbeing is coming from the Family Carers Ireland State of Caring report, which is a really, really great piece of work that if you're interested in learning about kind of where Irish caring is at, you should definitely check that out. When it comes to physical health, then 43% of carers report good to very good health. And on the surface, you kind of go, well, that's actually pretty good. But it doesn't mean that the other 57% said they have excellent health. Just spoiler. And that's versus 85% of the general population say that they have good to very good health. So really, it's about half, which is really, really just highlights an inequality there that is there for family carers. And obviously, back pain and exhaustion are some of the key problems that people will face physically. From a financial perspective, and these are definitely all from that Family Carers Ireland study, 68% of carers are in financial distress, 13% are in arrears with their rent or mortgage, and that's versus 7% of the general population, so that's double, are having those financial difficulties with their housing. And 23%, nearly a quarter, are cutting back on essentials to make ends meet. And that's not sort of, oh, I can't afford to go to the cinema this month. That's, I can't afford to eat every day, or I can't afford to pay my electricity bill. So those are the kind of essentials. So those are some of the impacts of caring that family carers as a general group share and will face. Well, then let's talk about being a part of a minority group in Ireland. And this data is from the census. So when we talk about, the majority population, 23% of the population in the census identified as something other than white Irish. That's nearly a quarter. So that's quite a significant number of people. When we say minority, it's not necessarily small numbers. 31% identified as a religion other than Roman Catholic. Again, that's nearly a third. 750,000 people, over 750,000 people, spoke a language other than English or Irish at home, and of those, 212,000 of these were born in Ireland. And there are nearly 33,000 Irish travellers living in Ireland. So that's kind of some of the data, I suppose, just to show that when we're talking about minorities, we're not talking about small numbers. It's a quarter of the population identifying as something other than white Irish. And then looking at sexuality, depending on the research that you look at, between 4 and 25% of the population may identify as part of the LGBTQ plus community. There is no question on sexuality as part of the census. So the smallest number there is coming from an Irish Times cultural piece of research that was done a little while ago, and the 25% is actually from the Growing Up in Ireland research data of young people growing up in Ireland and asked a question around their sexuality. So about a quarter of them are either part of the community or are questioning in some way their sexuality. So that's important to know as well. But, I mean, why does all this matter? I'm throwing out things that you hear. Why does it actually matter about being why does it matter about being a minority, and then how does it relate to caring? Well, if we look at the same sort of sections that I looked at before around caring, how does it impact? Well, 37% of LGBTQ plus people were discriminated against in the past year, and severe mental health difficulties are more prevalent in ethnic minority groups. So there's a higher prevalence of severe mental health difficulties within those groups. General anxiety, general sort of milder levels of mental health difficulties are around about the same, but at the higher ends of that experience, it is much more prevalent within ethnic minority groups. Physical health then, minority groups are much less likely to access health and mental health services because of barriers such as racism, stigma, and language difficulties getting in the way. And a small piece of an example of that from my own research for my doctorate is that there's a huge level of mistrust within the LGBTQ plus community around health and social care in Ireland in particular, especially because you have the background of decriminalisation only happening in the early 1990s, in 1993. So a lot of older LGBTQ plus people will have grown up with that feeling of risk of being legislated against, also being discriminated against, because a lot of our health and social care services then and still to this day are under the auspices of the religious community, which wasn't exactly the most welcoming in historical terms towards LGBTQ plus people. So that's some of the history there, and that's why people are a lot less likely to access the services that they need because of fear and distrust. From an economic perspective, then, minority groups are more likely to be in precarious employment. And from a recent piece of research, I found Black non-Irish workers are twice as likely to experience workplace discrimination. So you can see here that there is difference. There's extra, I suppose, there's extra challenges when you are in a minority group. And if you couple that together with the challenges if you're a family carer, you can see how it kind of compounds upon itself. I briefly wanted to just mention, I'm sure a lot of people here were aware that the Healthy Ireland 2024 report came out last week. And I know there's a big section on carers, which is fantastic because it gives us a lot of rich data. I won't lie and say I've read the entire thing. I have not. However, I have looked through it and I have seen quite a bit of it. And I did a search yesterday out of curiosity more for anything else. And within that report, and I'm not saying that they didn't do this work, but it wasn't reported. There was no breakdown of health outcomes by minority group membership in the Healthy Ireland survey that I could find. I'd happily be corrected on that. Please do. And like I said, I'm not saying that research work wasn't done and the data's not there. It just wasn't reported on, which I think if it's not reported on, how can we use it if it's not reported on? And I did a search throughout the document, that lovely Control F, just to give you a quick idea of what's in the report. There was no use of the words or phrases LGBTQ, of race, ethnicity, minority, traveller, or religion, certainly that I could find. I'll blame my computer if they are there and I didn't catch them. So that's just kind of an aside, but it just shows you that unless we actually talk about these issues in policy, in research, how then can we plan for what we need for people to get the services that they need if we're not reporting on it, if we don't understand what the issues are? So like I said, you've got caring challenges on one hand, you've got minority group membership challenges on the other hand, and then in the middle you have where they overlap, where they intersect, where they have minority caring challenges. And that's really something that we need to start talking about more and that I am advocating for in the next National Carer Strategy. And I have 2 more slides left, and I'm delighted with the timing I'm doing. So I have some examples here, and these are just examples of, because I think a lot of times people say, well, like caring is caring. Surely it's the same for everybody. Surely the experience is the same for everybody. And by and large, yes. If the services aren't in place for everybody, then nobody can access them. It doesn't matter if you're part of the LGBT community. It doesn't really matter if you're non-white. It doesn't really matter if the actual services aren't there, then it doesn't matter because you're not getting them anyway. But the way that certain things can impact you are different. And it's to be aware of those things, both at a policy level and also at a service provision level. So these are just examples I'm just going to put out there, and that there's no answers to them. I'm just going to ask you to kind of slightly imagine it, or maybe you don't have to imagine it. Maybe you are part of one of these minority groups and you're aware of this happening. So just imagine, for example, the trans woman who cares for her father with dementia, who doesn't remember having a daughter, only sons. The Muslim carer who only sees mass celebrations for family carers in his local area as part of celebrating. Imagine the gay couple who feel they have to de-gay the house before home care workers come in and visit. Imagine the Black Irish family carer who can only access bandages, etc. for white skin. Imagine the Indian family carer who can't understand any of the literature in the local health centre and is forced to bring her daughter to medical appointments to translate, effectively making that daughter into a young family carer. Imagine the Irish traveller who can't avail of any adaptation grants for their home as it's not a house. So you can see there that some of those issues are very specific to minority caring on top of the other everyday issues that family carers are facing in Ireland. So what does it all come down to policy recommendations wise? Well, obviously, we need to increase the research and reporting on family care in minority populations to improve our knowledge. That's where my PhD comes in, hopefully. But we need to increase that research, and it's even just from doing that piece of work, I've realized how poor a lot of the research and reporting on these issues are. Is it because we just don't know? Is it because we don't care? I hope not. I don't think that's the case at all from within the sector, but we just need to get better at it. Include specific actions re minority family carers in the next strategy. And again, there were none in that specifically spoke to minority caregiving in 2012. I think the closest we got was there was actions around young family carers, there was actions around male family carers. And I don't know if we can really classify them as minority groups in the same way. Encouraging services, including the HSE and voluntary organisations like ourselves, to include reference to minority groups in their literature and online presence, but obviously to avoid tokenism. And again, coming from my own research, even having something as simple as a same-sex couple holding hands or being spoken about as going to a family care support group or whatever it might be is really, really helpful in ensuring that people feel welcomed and knowing that they're not going to face discrimination within that service, because that is a real fear for so many people. So being just visible on the literature and being spoken about as a completely just part of life makes a big, big difference. And like I said, understand that many challenges remain. So the challenges that are there for family caring remain, but some of the solutions may need to be specific depending on the cultural context of the family carers that are experiencing those challenges. So that's me. Thank you very much for listening, and I'm happy if there's any questions to take them, which I don't think there is in the chat. I've just spotted. So.
Thank you so much, Zoe. That was a very, very interesting presentation. It's I suppose it does encapsulate as a beginning all the groups that are there, how we actually define minority groups, because in general, OJA, so just when you're talking with researchers or clinicians, there is that predefined definition again. So it's really interesting there that AI use you did to provide an image of what is caregivers for the internet and all the data we're giving to the internet or just general devices. And there is that predefined idea that's very strong if it's coming out there in the recent years in 2024 when all this digital progress has shown. So it's a bit worrying in the sense that to kind of break them, we really need to bring that knowledge but out there, not just the interviews and understanding it. And it really does provide food for thought the way you present it there, and it does show us how complex it can be. So I don't know if anyone has any questions following this talk. I certainly have a few, so if there isn't, I can jump in, but I will leave a few more minutes for people to reflect. Any on the chat? I do not think so.
No, I don't see any in the chat. Don't be shy.
Fiona, please feel free to go, Fiona.
Hi, Zoe. That was a really interesting presentation. And just a few observations, but just one particular observation. And relation how society creates and recreates minority groups and give them labels. And if we can create it, then we can recreate it, but in a different way. And we have the power to do that collectively in a very person-centered way, given the opportunity.
Yeah, absolutely. These things are always very fluid. I mean, there are some categories that you kind of that are in some ways static, like you either are white or you're not, essentially, you know what I mean? In some ways, there obviously are some there that are fixed, I suppose, in a bit more of a way. And I don't want to speak on that. Obviously, I'm part of the minority group myself, but I'm not specific one, so I don't like to comment on those. But absolutely, I think your point is very valid.
To jump onto that as well, there's that cycle where when you are in a minority group, there's a lot of statistics showing that you do have more stress, you encounter more difficult situations or more higher annotated stress levels, that then goes on to then higher possibilities of one day encountering a position of caregiver. So there is that cycle there that we need to focus on. We are forgetting, I think, a few groups there, and we really need that knowledge and quick enough, because I think we are not aware of how many people are actually in that position. And also there is, just as a side point, a lot of research again, but I did read recently about that minority groups do tend to diminish their stress level. So they don't believe that they feel stressed because they've encountered so many difficulties through life that their baseline is solid, you know? So there is that cycle that would be interesting to kind of bring out there, and to, you know, to disentangle a bit more. But yeah, definitely, Zoe, thanks. That was very innovative, very new.
It's definitely one thing to note. I mean, from my own PhD research, you have a much higher likeliness of becoming a family carer if you are part of the LGBT community than the general population. That doesn't mean that there are more LGBTQ carers than none. It just means that within that smaller pool, you are much more likely. And some of the reasons behind that are things like family of choice and you know, creative families within that community. So there is definitely something around that as well. And you're saying stress levels, you know, people's baseline in a minority group because of the structural difficulties and structural barriers that they face entirely throughout their life, kind of just, I guess, become numb to it a little bit and kind of go, it's just one more thing. This is one more thing. There's no point talking about that. There's no point getting into that. Let's just focus on the here and now. But, you know, we have an opportunity for those of us who are slightly outside that but understand it to actually start to challenge those structures on a policy level as well. I think is very important. Obviously, bringing it back to the national care strategy, if we can start to think about including those things and actions in any next strategy, I think will be really important.
Yeah, no, definitely. And there's also the idea of categorizing in minority groups, which is, you know, labeling generally doesn't help society, but we need it to then structure, you know, general legacies, or, you know, to help moving towards health outcomes. And so there is that, you know, point of reaching out to those people that we forget as well. So it's a lot of work to be done, Zoe, anyway. So I'm looking forward to seeing your PhD work, because I've never seen, you know, it's very, very new. I just see a question there. So, hi Zoe, do we have any figures on how many carers have disabilities themselves, but are caring full-time for someone with complex needs? In other words, a double-edged issue. Thanks, Julie.
Yeah, Zoe, absolutely. We, off the top of my head, no, I don't know if they're publicly available. I know you would be able to cross-reference people who are identified as caring within the census with those who then say they also have a disability or disabled, and because those figures are available within the census data, you'd obviously have to ask specifically for that. And then when you're asking about caring full-time for someone with complex needs, that data isn't necessarily there or asked, because you're not asked who you're caring for in the census off the top of my head. So I'm not 100% certain, but there is definitely a lot of people think, you know, disability and care are, if you're either one or the other, and that's just simply not the case. You know, it's absolutely just not the case. So I think it's really important to remember that too.
Wonderful. Thank you, Julie, for the great question. It's good to precise. So Brian jumped in there on the chat, mentioning not aligned with full-time care, but the Healthy Island Survey 2024 found that 44% of carers report that they themselves have a long-standing illness or health problem. This compares with 36% of those who are not carers, which is really, really powerful statistics to have. Yeah. Thanks, Brian, for that clarification. Okay. I think, that's enough figures for today. At least we are very clear on all of this. So we're now going to jump on to the next speaker that we have today. So we have Kerry that's on the third speaker today, because we did have Liam. So Kerry Cuskelly is the Chief Executive Officer of Exchange House. So we're delighted to have you here. It's really, really nice to have that perspective as well in this talk. So Kerry will be discussing family care considerations with the traveler community. So a very specific group there. So it will be really, really interesting to hear your thoughts as well. Now that we're talking about all these little groups you can find and really dive into, the different worlds. So thank you, Kerry, for that.
Great, thank you very much. Can everyone hear me okay?
Yes.
Excellent. And can you see the slide? Even better. Great stuff. That's wonderful. Okay. So thank you very much for having me here today. I really appreciate the opportunity to join this conversation with specific focus today, but I suppose I have worked across a number of frontline services in health and social care for many years, and have worked with families, supporters, communities, individuals, groups in many different guises. And I suppose the overall concept of family care is one that I've always had some sort of connection to or input in over the years in different forms. I suppose I would caveat my input today saying that this is very much just some considerations. Definitely, it is not on the level of PhD or formal research study at all. But I suppose it is trying to just, I think what Zoe was saying and what Liam was saying before, just bring some thoughts into the conversation that we need to have and that absolutely just has to be had prior to any further strategies. And I will be controversial, Zoe, sorry, later on I'll be opting for not strategy, but more strongly worded words than that. But certainly we do need to take stock, we need to step back, and we really do need to consider the concept of care in general, because before we go any further, care is a human condition. Everybody either will receive, need, give, be interacting in care throughout our entire lives. We wouldn't all be here today if somebody didn't care for us and get us from birth to where we are now. So it is not something that is alien to us. It is not something that is other. It is not something that is for any particular group. It is not even, it doesn't need a label per se. It is a human condition. So I think we need to come at it from that perspective as well. And actually, I apologize. It is more than just humans that need and give care, but in this context, we're just talking about humans today. I suppose just very briefly, I'm going to presume these slides will be available afterwards for people to look at their leisure. So I don't need to spend a huge amount of detail going through everything that I'm going to talk about, but I've put as much information as I think might be useful on the slides for people to then maybe look at and consider after today. Briefly, these are the pieces I'll very briefly touch on: population age profile, health considerations, structural considerations, cultural, the issue or the concept of conditionality, which is something I'm interested in terms of the lived experience of policy and how important policy actually is. While it can be very positive, policy can also kill. And I think that's really important to know. It has a very, very large and substantial impact on people's lives. And I know that might sound alarmist, but it is not. And it's just to consider the issue of policy and the importance of the conversations we're having in real life and in real terms. And conditionality very much has an impact on people's lived experience. And the concept or the thought of prejudice, discrimination, and racism in policy, and again, how we can implicitly or explicitly write and create and recreate cycles of prejudice and discrimination in the very words we write and in the very conversations we have. And then again, how that can impact on people's lived experience and on their day-to-day lives. Going to the shop, going to school or not, leaving your home or not, if you are lucky enough to have a home, moving to and from places, just very ordinary day-to-day lives can be very much impacted by discrimination, racism and prejudice. And then at the end, my controversial policy versus strategy. I'll tell you now, spoiler, policy is what I vote for as opposed to strategy. And then concluding remarks. So just very briefly, Exchange House Ireland, for those who are not aware of it, is an organisation of travellers and non-travellers who work together, and we provide frontline services and services of excellence. And I say that objectively, because this is the important piece. We really want to provide, as everybody should want to, but unfortunately it is not the case, that people receive quality services, quality, safe, effective services for everyone. And I suppose that is one of the main reasons for Exchange House Ireland. The services we provide are frontline, but they are with the aim of providing to the traveller community services that everyone should expect. High quality, highly professional, highly skilled, highly I suppose highly safe, highly effective services that are evidence informed. We want to live in an Ireland where travellers are fully valued as a distinct ethnic minority, and that people receive genuine, equitable treatment and access, and that there shouldn't be any issue with that. It should just be the norm without barriers. The background to Exchange House, it started in 1980, so quite an old service and an established service, initially in Dublin city centre, focused on family support and education, but now we provide services across the lifespan. So the idea of here is that you ring, you come to the door, and there's no wrong door. You will be supported in whatever it is that you need at that point in time, and you will receive an equitable service. So very briefly, I know the number that Zoe presented previously in terms of the exact numbers of the traveller population was the very specific correct number from the last census, which I'll absolutely agree with. But I suppose in terms of where the traveller community may live, they may not specifically literally be in the Republic of Ireland at any one time. They may be across Northern Ireland, they may be across the UK, and indeed across the entire world. So I suppose in terms of the population profile of the community that might be connected to or feel culturally connected to Ireland might be in or around the 40,000. But broadly, I think 6 people in every 1,000 will be a member of the community. The age profile, these numbers are slightly dated, but correlate pretty specifically or pretty well with the most recent numbers in the last census in 2022, because I checked the numbers before the presentation here. I think the main thing to note is that consistently our traveller colleagues and friends are a younger population than the general population. And again, when we think of caring, again, I'll put out not to be alarmist again, but I'll put out a suggestion that 100% of the traveller population are carers in some way, shape or form. The reason I say that is because health levels across the entire population for all types of health issues are poorer than the general population. Many or most of our traveller friends and colleagues have multiple health issues. And we'll also add, because I think, again, when we think of the assumptions that you were talking about, Zoe, previously, when we think of caring and we think of health, we tend to think of maybe very specific health conditions. And a lot of the times mental health is not included in our understanding or our thought process around disability or around needing support and care at various points in our lives. But we all are very clear, and I'm sure everybody here today is well aware, that mental illness and mental health and suicide in the traveller community is exponentially more prevalent than it is in the general population, and every single person in the traveller community will be impacted by in some way, shape or form. And I mean very much in terms of immediate family or immediate supporters will be impacted by mental health and mental illness. So in that respect, we really should be starting from the assumption that caring is the default, so 100%, and we can work downwards from there. So in terms of being a minority issue, it isn't necessarily a minority issue, it's actually a default consideration, and we should be working from that perspective inwards then when we're thinking about our traveller colleagues and our traveller friends and communities. So again, in terms of health considerations, travellers are twice as likely to have longer term chronic health illnesses than the general population. The suicide rates are much higher than the general population. Respiratory diseases are quite stark, heart disease, stroke. So none of this, I imagine, will be of surprise to people. It is just very, it's very hard to consider these in a real and a real, I suppose, human form unless we see it over and over again, and unless we talk about it more. And I think this is what today is about. I would hope is the beginning of a longer term conversation around the realities that we do need to think about seriously if we consider caring and the investment we need to make for caring in Ireland, and in how we approach the concept of caring for each other and caring for everyone that we live beside, work with, are friends with, support ourselves, that we as a society should be coming from a caring perspective. And how do we do that in a very tangible sense? So just thinking of structural considerations. So like I've noted previously, travellers have significantly poorer health than other groups. There are higher incidences of long-term health conditions, but there's also correspondingly higher levels of unpaid care. And I suppose the concept of being an unpaid carer, we'll say in inverted commas, isn't necessarily something that's talked about, we'll say openly, or not that it's shied away from, but it's just not something that maybe people in the community talk about. And that's because caring is seen as something that people should do for each other. Caring is actually a cultural core of the tribal community. The community care for each other, families care for each other, siblings care for each other, parents care for children, vice versa. So caring is seen as something that you do because we're family, we care for each other, and that's what we do. So in that sense, it is something that we might need to tease out a bit more and just talk about a little bit more in terms of when we say family caring, what does that mean in different cultures, in different groups, in different cohorts of society, and how can we, in terms of the state, actually then respond accordingly so that we talk in a way that everybody understands, everybody connects with, and then everybody can hopefully engage with. So that idea of culture of care, and I think this is across a number of different levels. So the culture of care in terms of the ideals or approaches to care that's associated with different traditions, cultures, ethnic groups, but also in the cultures of care that exist in our, I suppose, our organizations, in our services. How care is conceptualized is something we need to think about as well. And then how care is actually translated into practice through responses to, we'll say, neoliberalism and market regimes and the labour force, and how care is actually conceptualised and implemented, and how all of those then interact with each other. They're all things I think we need to talk about and tease out more and come to some type of an agreement or a decision on in terms of a future maybe strategy or policy in terms of caring. For the traveller community, by and large, care is about mutual support. Care is accepted as a normal part of life, and it's a shared responsibility. So those are all things that need to be accepted and need to be understood and need to not be penalised in terms of how the state responds to caring. They need to be, leaned into, acknowledged, and the system needs to work with that in terms of how different groups conceptualise care. So traveller, like I said previously, traveller families expect to care, and they do so willingly, and don't necessarily see themselves as carers, but just, humans care, people care, we care because we love each other, we want to care for each other, we want to support each other. However, in terms of gender, and I think Zoe talked about this previously in terms of just that intersectionality piece, the bulk of caring then does tend to fall on women and does tend to fall on one main carer inevitably. The other piece I just wanted to bring into or throw into the conversation was the notion, or is the notion, of conditionality. And I suppose this is, I know this may be in people's minds in terms of maybe the means testing for accessing support if one decides to self-declare as a carer, and how one then receives support as a carer, or indeed for any part of the welfare system. But linking conditionality to eligibility, that in and of itself creates a lot of barriers for people. If we have a community, it could be the traveller community, but it could also be another community, and like Zoe had alluded to, LGBTQI plus colleagues and friends, there may already be a mistrust in the system, and even declaring any part of myself for the system in order to access a support might be a difficulty. And then if I also have to declare that I am also a carer, and I have to define myself in a particular way, that the state says I have to define myself in order to access support, that in and of itself creates multiple barriers. So if I'm already discriminated against because of my ethnicity from entering and accessing support in the system, and then I also have to jump through particular hoops in order to qualify for usually quite a minimal and below inflation rates and below standard of living amount of financial support as a carer, then that is something that maybe I will choose actually not to engage with. So conditionality, I think, in and of itself is something that really needs to be looked at as well in terms of the concept of universal supports, and not asking people to have to agree to be a certain thing or agree to a certain label in order to access the support that would just help somebody live a dignified and meaningful life and improve people's quality of life, which is what we should be striving to as a society. The other piece is to think of, in a broader sense, or even on a baseline sense, or as a maybe in terms of in the round, is to consider how prejudice, discrimination and racism is and has been for many, many years, and not just for the traveller community, has been within the structures of our policies, within the structures of our organisations, and manifests itself in how people experience services and how people engage or don't engage with services and with policies and with strategies. So we really do need to consider how we develop this conversation, how we ensure that what we produce in the next care strategy or care policy, how it meaningfully is inclusive and how it isn't just a tokenistic consultation or offer of inclusion to groups, whether they be from the traveller community or other groups in society, and how we need to really, really genuinely take a step back and look at how we deconstruct a lot of the policies or legislation that already exists, and ensure that when we move forward, we do so with people and not for them or at them or to them, or leaving them out entirely in terms of excluding them. So I suppose for me, when I was considering this conversation and thinking about the next care strategy, I would prefer to think of the first national carers policy. I think we need to move to, I suppose, meaningfully resourced policy and policy implementation. And we need to acknowledge that, again, as I said previously, care is something that is it's societal. It's not just the purview of a particular group of people that the rest of us can then ignore or not engage with. We need to think of it in a whole of government approach. We need to think of it in a whole of society approach, and we need to think of it in an inclusive way from ground up. So I suppose for me, my thoughts were, how do we ensure that new policies don't replicate previous systems? And I've noted a number of pieces of policy there over the years, specific to the traveller community, that really impacted on the community and still does impact in terms of policies that were assimilationist and are assimilationist, policies that were overtly and implicitly racist and discriminatory, and that really genuinely has impacted people's lives over the years and continues to. So any policy or strategy that we do develop, we do need to consider deconstructing it and deconstructing past policies so that we don't make the mistakes of the past in the future. So my concluding remarks and suggestions and hopes are that we would be proactive. So instead of being able to luxuriously say, oh, we are trying, but some groups are hard to reach. Nobody's hard to reach. We're not reaching out enough. That's our problem. That's not the group's problem that we can't reach. We need to reach harder. We need to do differently. We need to be different. We need to do more. And I say that as a white settled Irish person. So it's on me and it's on everybody here like me to do more and do better and do it now and in a different way, to engage with communities who are quite happy and would be delighted to be talked to receive services to receive equitable treatment, as long as they are treated with dignity, with respect, and with the rights to which they should be entitled as humans. So I say that we need to be proactive. It needs to be a systemic approach across all departments of government, across all levels of our public and private institutions across the country. A consultation needs to happen, but at design stage. So without having a draft sent to people of anything, whether it be a strategy or policy, we need to have conversations first, like today. This is wonderful. I think if there were national conversations like this on a rolling basis for the next year, 2 years, however long it takes, in a genuine manner from grassroots level, to then develop what a co-produced and co-designed and co-created community-led policy might look like, I think then that would be something that would have a very good chance of happening, of being accepted by people, and then of being meaningful and real for the people to whom it's supposed to support. And I think, yeah, I've said the principles of universality, the policy as opposed to strategy piece, and a cross-governmental approach. So a lifespan approach, because for the traveller community, and I'm sure for others, there are many young carers. Carers can take lots of different forms across the lifespan, and caring, again, doesn't just start at a particular point in time. It's an all of us issue, not just a particular point in time issue. So I will leave it at that. Thank you very much.
Thank you, Kerry. That was very complete as well. In the sense that I know we're restricting everyone. We're very cruel in Kerry and Ireland to keep all these timing, because it's really you know, there's always a continuous end of it. Like, I would nearly want to ask you what's the ongoing research projects at the moment, you know, but I suppose just to keep it concise, I have just one little question. I can see Brian has his hand up there as well. I'll come to you in 2 minutes. Just quickly, more of an information piece, Kerry, now that we have you here. I have a lot of people living with dementia in the community that do identify as part of the traveller community, but don't know how to engage with research, are a bit scared of the first step, but do have a lot of to say, and especially would like to join the legislation points of debate and the carer strategy as well. So there's a lot going on in the communities. I've had a lot of conversations. Where would you guide someone that maybe never engaged in research before, living in the community, and especially in the domain of dementia? If you have any insights, that would be great. Thanks.
Sure. So just so I understand you correctly, you're wondering just around people with lived experience of dementia,
yeah,
being actively involved. Well, I suppose I don't want to name drop people right off the top, but I do know that I mean, there's really excellent work being done. Carmen, are you in UCD? By any chance?
So I'm based in Maynooth. I'm working with UCC.
UCC.
No,
apologies. So Sarah Donnelly in UCD is doing a huge amount of work with dementia related projects, and very much inclusive, user-led, and I suppose, yeah, participatory research. So that's certainly somebody who I know off the top of my head. And I do know that and I'm sorry now, I'm probably going to get the name of the organization incorrect, but there is a dementia specific NGO that also is doing really excellent work, and I can find it offline and send it to you. But again, around people who actively have dementia but are engaged very much in terms of their lived experience, and being part of a research process. Yes, so there are, yeah, I'll stop just there. But in terms of, I suppose, engaging or meaningfully having people from any community be part of a research process, I suppose for me personally, individually, anything I've been part of, and I suppose I've done over the years, I've been involved in lots of different we'll say co-designed and co-created projects. I think the main thing is not to promise anyone anything that you can't follow through on, and that people know ahead of time. Thank you. So yes, that's correct. That people know ahead of time what's going to happen, and that actually that their input is not just going to be for the benefit of you or I, you know, that I will get an article published out of this, or I will get, you know, a PhD out of this, but actually that the research that's been done, the point of it will be to make an actual, real and tangible difference to people's lives. And mostly people who engage in research will never find personal benefit from it, but as in it won't make any necessarily difference to their individual lives, but they will know, and they know that it will make a difference to others who may be in similar situations in the future. And I think that's the key piece, is that the research that we do, especially and will always default, should be co-created with people from the get-go, from the design stage. There should be no design bringing to people saying, look what I've done and would you like to be part of this? It's actually, I would like, you know, this is something I think that I'm hearing from the community that's important. Would you like to have a conversation about this? And can I support the development of, or can I do something to help you make a difference in this area? And then, you know, we do what we do in terms of the research piece. So I think that's, for me, ideally where conversations would start.
That's fab. Thank you so much, Kerry. That's the implementation piece, again, I can't agree more, is what we need to emphasize, really bringing it the long term, the findings out there to those who need it, rather than publishing and keeping that certain tradition that we have. But we're growing on that, and I have no doubt, Kerry, that you will assume that. I can see the energy and dedication you have in your work, so it was just amazing to see. Thank you. I'll go on to Brian just for time purpose. I can see it's going quick. Go ahead, Brian.
Yeah, so firstly, thank you, Kerry. And I suppose my question, it kind of speaks to Kerry's presentation and also to Zoe's. And I suppose what's important to think about, yes, family care, is that they have multiple different facets of their life, but it's also, if we're thinking about the National Carer Strategy, it also sits in relation to a number of other strategies. So there's the National Traveller National Traveller Health Action Plan, there's the National LGBT Inclusion Strategy. And so what I suppose was, I'm just curious from the presentations, is what are the specific issues facing traveller family carers that you would like to be addressed in a national carer strategy?
Me specifically?
Well, you
or sure, no.
Yeah.
No, I'm joking in one sense, as in it's not my answer to give, if that makes sense. However, I suppose the reason I was very, I suppose, passionately asking for a whole of systems approach is because it is also interconnected. And if we want to think of it in very, very practical terms, in order for me as a carer who, you know, is a member of the traveller community, who lives in substandard accommodation most of the time, my accommodation needs to be appropriately supported and developed. I need to have easy access to the areas that I live and I work. So my physical environment in terms of my accommodation impacts directly on my ability to support and care for somebody. So we need to look at the issue of accommodation and housing and culturally appropriate housing. So it absolutely, literally the lived environment. Very often in terms of the physical and lived environment, if I'm a member of the traveller community, I am looking out, like literally looking out the window of wherever I may be living, into an industrial estate, into grey, into cement, into no green, into no play spaces, into no footpaths. You know, it's so the actual the lived environment that I'm in also needs to be addressed. So I suppose the housing and accommodation piece needs to very much cross over with the caring piece, needs to cross over very much with the, we'll say, financial piece in terms of habitual residency conditions, paperwork that might be required in order to, you know, the state to acknowledge that I even exist in order to access supports. So I suppose all of those different policies that exist need to be, I suppose, quality proofed, but also need to talk to each other very clearly and very well in order for the caring piece to actually then be easier or be feasible. So I don't know if that is maybe what you're asking, but I think that's why everything needs to actually be reviewed with the lens of caring in order to look at the impact of the caring, because it's not a tangible, it's the indirect impacts very often that make caring very difficult. Not the actual act of wanting to care for another human being, if that makes sense.
Wonderful. Okay, so we're still on track of time. So if that's okay for everyone, we'll go on to our next speaker. Thank you so much, Kerry, for this great presentation. And well done for the time. I know we were worrying about it before. You did great, very complete. Okay, so we'll go on to our next wonderful speakers. So we have scheduled Kearney and Fiona Weldon next. So Kearney is Policy Assistant at Independent Living Movement Ireland, and Fiona Weldon is a Capacity Development Officer at Independent Living Movement Ireland. And both today will emphasize the importance of embedding the collective lived experience of disabled individuals in the development of new support strategies. So it's going to be a great presentation, so we're looking forward to it. And thank you so much. Over to you.
Yeah, hi, thanks for that lovely introduction, and thanks to Zoe and her team for inviting us here today. My name's Claire Kenny, and I'm with my colleague Fiona Weldon, and we work for Independent Living Movement Ireland, or ILMI. ILMI is a cross-impairment disabled persons organisation. We're made up of and work for disabled people by disabled people. That is working diligently towards the removal of systemic barriers that exclude disabled people from living lives and also impede them from being productive citizens. Our question we pose to you today is, do we actually need another care strategy, or do we need an alternative strategy that promotes user-led, person-centered supports that gives disabled people our lives back? It's a win-win for everyone.
Thanks, Claire. My name is Fiona Weldon, and I work for ILMI. It took me a long time to say ILMI because it's for the, yeah, but I am the capacity officer, and that's around building people's confidence, self-esteem, and self-worth individually and collectively, but also building our allies around what we need and what we want around the provision of support in relation to living our best lives. And so setting the scene, so like everybody has mentioned it, Zoe and Kerry and all the other speakers before me has, and we all agree that historically our government has never taken people into account, including disabled people. And we have been left out of policy development and practice. And this has allowed non-disabled providers and umbrella, organizations to speak on behalf of us, but also, like Zoe mentioned, that we're all intersectional, and disabled people are intersectional too. And I think our government needs to be held into account, and because they assume that families have an obligation to provide any or even all the additional support that their loved one needs. And this can include 24-hour support and medical interventions without paid support or even breaks. And they're also forced to fighting for essential services, and they're also forced into poverty, into giving up. They are forced to give up their work or their professional and jobs or whatever. And we know that parents and families do play a very significant role in society, but they need the provision of additional support services, whatever it looks like. And we think that parents just need to be parents. And also, it's an issue that aging parents worry about what will happen to their loved ones when they're gone. And many of them are put into or assigned to residential services and end up in nursing home care also. And carers, home helps, healthcare workers, and the carers allowance is also an issue. It comes under the same kind of funding stream, and it's easier to get a place in a nursing home centre as opposed to receiving home support in the form of personal assistance. So that's a huge worry for us. And also our system is very system-centred, and we are forced into services that we don't actually fit into. And we are disabled people are over medicalized, and it focuses on our perceived deficiencies and what we cannot do, even though we can do, and with support. And an awful lot of the time, only our basic needs are supported by a home health or care workers with very minimal hours, like even half an hour shifts for people to get up and get out of bed or go to bed. And this is really only surviving, helping people to survive, but not living. Relying on family, we know, limits our choice and limits our freedom and puts other people in control of our lives. And this can create very toxic relationships. And there's lots of research to back up this and relying on family members. And we fear, and we're very, very afraid that when parents lobby for residential institutions, that this will increase demand, because that's what our government and our HSE is only kind of able to do. And this will eventually demand, inevitably, in warehousing of disabled people, regardless of the support level or needs.
Yeah, so care implies that all disabled people need to be looked after. It implies that either adults are being infantilized or that disabled people are sick, which shows how prevalent the medical model still is. It assumes a power imbalance. The carer, paid or unpaid, looks after somebody who is unable to do or make any decisions. Healthcare needs are different to our support needs. Some of us need healthcare professionals to support, but most do not. Personal assistance services are very different, to access. Even through disability movement has proven over and over again this provision of support works. Yeah, so that's very important to consider. And I suppose what this comes from is disabled people ourselves have come up with this, like a collective of disabled people ourselves and our members have come up with the fact that that the term care can be problematic for us.
Okay, thanks, Claire. Jenny Morris, about leading disabled activists, feminists, and academics, says doing care on us takes away our autonomy, and the assumption that carers are in charge. And this is very worrying, and I've seen this over and over and over again. And then being reliant on family members strips us from being mothers, dads, daughters, brothers, sisters, aunts, and vice versa.
So the UNCRPD, we've been talking a lot about different policies that have been put in place, and you know, I suppose the traveller policy was mentioned there earlier on, but one that's very relevant and should be part of a new support strategy is the UNCRPD. Ireland has ratified the UNCRPD in 2018, and just recently, actually in November, finally adopted the optional protocol. In that, Article 19 recognises the equal right of disabled people to live in the community with whom and where they want to live themselves. Article 4.3 states that DPOs must be involved in policy and legislation that affects our lives. They must consult and co-create with us. The social model of disability frames the UNCRPD. Impairments and disability are separate entities. Independent living is about agency, self-determination, and having real choice and control. Disabled people must have the right to choose who supports them and at what times. And this brings us very nicely on to Not in the Driving Seat, which examines how disabled people perceive or feel when it examines the impact and reliance on family, highlighted the absence of research on the impact reliance on family has on disabled people themselves, and the four emerging themes are spontaneity, choice, compromise, and privacy. And you can we'll send a link to Zoe later. Maybe she can circulate it to everyone. This is a research study that we did, and a personal assistance service enables disabled people to have fun with their families and live spontaneously without planning too far ahead.
Okay, thanks, Claire, for that. And again, we can send this to Zoe. And we know that family carers, healthcare workers, home health, special needs assistants are restricted by design. And in regards to funding, funders, but we know the providers make the rules, and some of them are really cashing in, and there's no quality of life outcomes. It perpetuates ableism and internalized ableism, and this is by assuming that the normal way of living is not living as a non-disabled person. And it's able to believe that non-disabled people are more valuable to society than disabled people. And obviously it's a form of discrimination. It creates low expectations for parents, disabled children and adults, and it creates passive recipients. We become very compliant and we make great service users, and creates and recreates segregated systems and structures and keeps us out of the normal rhythms of daily life living, creating day centers, residential service, special schools, SNAs, and so forth. So we are promoters of independent living as we define it. It's embedded in the social model of disability. So people live with their impairments but we face many barriers in society, and these can be deconstructed. And barriers can include attitudinal, environmental, policy, and the lack of the right support to prevent us from living a good life with choice and control. And disabled people, I think all of us want to live self-determined lives with choice and control. And we're going to show you a short video on what personal assistance is, because that's what we're really advocating for.
Personal assistance is a concept that comes out of the disabled people's movement. Rather than being dependent on family members or care workers in an institution, disabled people can live independently in the community, supported by workers who they pay directly and therefore control. Simon Brissenden, independent living pioneer, said, "We need to be clear about what we mean by independence. We're not talking about being able to do everything for yourself. Neither does it imply cutting oneself off from the assistance of others. For what matters is not whether you do something with or without the help of others, but that it gets done under your direction. Being independent simply means that you have some control over your life and that you don't live by the routine of others." Personal assistance avoids dependency. Instead of having to feel grateful to other people for their kindness, disabled people are paying for their service. It's a contractual exchange. The worker gets their wages, the disabled person gets things done which they couldn't do for themselves. Neither party loses out. As a result, personal assistance is empowering. The disabled person can decide who supports them, at what times, and in what ways. They're in control. This is revolutionary and transformational for disabled people. Personal assistance is also flexible. It can be different for different people and on different days. A personal assistant is different from a carer or a health professional. They answer to their employer, the disabled person, and work under their direction. Personal assistance relies on the working relationship between the disabled person and the personal assistant. In fact, there can be a series of working relationships between a disabled person and each person who works for them. Although this is a reciprocal relationship, because one person is getting paid and the other is getting support and assistance, it is still a human relationship with all that that entails.
Okay, thanks,
Personal
Claire.
assistance
So
is a
it's about, okay, so it's just important to say that we've asked, like all of our members around the country, in regard to the terminology around care and carers and whatever. So we're saying that we need support, but it's not about care. And it's not about doing care on us. It's about supporting us to live the best lives we can.
Yeah, and to that end, we have a national campaign. It's called the Pass Now campaign, and it's to define what a personal assistant is, to legislate, to invest, standardize, and promote personal assistance. And you can see we have a quite extensive explanation of the different steps we've taken over the years, starting from 2018 ongoing, to make that a reality for disabled people.
Thanks, Claire. And I think a personal assistance service can support everybody, not just disabled people, young people, older people, and obviously, family that are reliant on support, but like are reliant on not having that support either. So we think that government must step in to any sort of supporting strategy going forward. And so I'm not sure if you heard about the consultation to co-creation project, and it was developed by Inclusion Ireland with us and with input from advocacy groups and local disabled person organisations and other disability and stakeholders. So it was commissioned by the HSE in 2002 and it was published in 2004. And it's a guided document about enabling the effective participation of disabled people in planning of the support services that we need, and also around making decisions. And we're really excited and delighted that for my timer just gone off. Sorry, Zoe. And so the HSE has commissioned us in partnership with Inclusion Ireland to run a pilot project, and around and document best practice, best models in disabled people using HSE funded disability support them to support them to live good lives, and they're in Donegal, Sligo and Meath. So, like, we have another policy document, and it's taking control of state-funded disability services, which coincide with the co-creation or the consultation to co-creation project. And it's really about us having real choice and real control and co-creating and with service providers to make sure that we are getting what we need to live good lives. But if we continue to use to do what we're doing, nothing is going to change, and it's going to limit our choices. It's going to be listening to non-disabled people and and speaking on behalf of us. And until this happens, and state funding will continue to be provided through segregated services that limit our choices, patronize us, paternalize us, and deny us our right to agency and choice in our lives.
So finally, our recommendations. Parents and family role must be valued, but not at the expense of disabled people. Experience of being infantilized or paternalized by the term care, must start to talk about a system of support inside and outside the home in social, educational and employment settings, moving towards conversations about how we invest in inclusion, removal of barriers. It benefits everyone. Again, it's a win-win. Understand that language matters. It frames our thinking. Language can constrain our thinking and limit how we view groups of people. By always resorting to talking about care, disabled people are without doubt promoted to a passive role where their views are not regarded. We need to campaign to invest in supports that meet the needs of disabled people to be part of the community. The needs of disabled people, regardless of their impairment, and needs for family carers will be met. Independent living should be about every disabled person, regardless of their complexity of support needs, having what they need to live their lives to their fullest potential. Parents need to expect more from clinicians, from our education system, our healthcare system, service, work with local and national DPOs. Appropriate supports will liberate disabled people, and appropriate supports will liberate families at the same time. That's really important. Appropriate supports will liberate disabled people, and appropriate supports will liberate family members at the same time. Thank you.
Thank you to you both. That was a great presentation. So it's hard to get better and better, you know, more we're going forwards. You know, they're very, very strong presentations, and you can see the patient going through the whole conversation, and a lot of learning there again. Does anyone have any particular questions for Claire and Fiona? I know we're just on time, so we might have place for one question. So if anyone has any thoughts, comments, feel free to put your hand up or put them on the chat. Okay, Zoe, do you want to go ahead? I've got some thoughts too, but go on.
Oh, sorry. No, I was just wondering,
No, go.
language is something that I'm very passionate about, in the right language use and using the right words to describe people the way they want. But I suppose, and I agree that kind of care is not going to suit in every situation by a long shot. It's not appropriate, you know, but it's become the shorthand that we tend to use, you know, and I include myself in that. But I suppose the dilemma for me, working in where I work, is that for some people, care is what they want to use, and even the cared for person themselves, as in older people, or you know, they prefer that usage. And I suppose I'm trying to figure out ways to respect everybody in this situation, you know, that kind of way, and to prioritize the people who are in receipt of the supports in the way that suits them best. It's not a question. I don't think there's an answer to it, if you know what I mean, because I'm not too sure where that goes, because it's a thought that popped into my head, you know, is that some people, but then is it some people identify with that word because it's been used for so long and that's what they're used to? Is that what it is?
Yeah, I think it's like we could talk about this forever, I think, you know. Yeah, we could. But like, you know, and like Kerry talked very passionately about, like, we are a caring, we want a caring community, we want a caring society. We all care for each other. It's part of the human condition, but doing care on it. So I think, Zoe, it's about the power dynamics.
Yeah.
Okay, so I think for example, my dad is 81, going on 50, or thinks he's going on 50. And, you know, so we support him to live a good life because my mom isn't around anymore. But I don't see that as a power. It's not something. It's something that, you know, and Kerry spoke about this as well. It's something that we do. But like, we know that there is so much abuse, you know, in relation to older people and disabled people and younger people, you know, and like people in direct provision. Their rights aren't respected, and we devalue them. Okay, so like, if you're coming from a good place and you are really providing the best support that you can and for your loved one, you know, that's great. But like, if your loved one needs or wants additional support, and that should be provided by government. And we know historically that they haven't provided that. So I think any strategy, you know, going forward, you know, needs to take into account, you know, everyone's lived experiences, you know, like we're not devaluing. I'm married. My husband cares for me. I suppose I care for him, you know, in that like he does what I need him to do and I do what he needs me to do, you know, so it's reciprocal. And but I suppose there's a quote I always use, you know, and at the end of stuff like this, you know, and it's about, you know, and you quoted the lady earlier before Zoe, and it's about do the best you can until you know better. And then when you know better, please do better, because there's so many people that are not supported, you know, including, you know, family and parents that need that support to support their loved ones, you know. So it is very much about the power dynamic, Zoe, I think, you know. If that answers your question.
Yeah, absolutely. No, thank you.
Thank you, Zoe. Thank you, Fiona. Fiona O'Neill, I think you have a question there. You've got your hand up. Fiona, unmute.
Can you hear me okay?
Yeah.
Can you hear me?
Go ahead.
Brilliant.
Yeah.
First of all, from one Fiona to another Fiona, as a parent with someone with a son with disabilities, their statement that said parents just need to be parents, it actually hit me in the stomach when you said, so thank you for even making that statement. So I don't know if it's something anyone else might be able to help me with. Claire mentioned UN CRPD. Is there any conversations at a European level about carer strategy? And saying that, now again, this is just my opinion, that government seems to act faster when it's fed down from Europe rather than when Ireland is trying to say it. So is there a European family carers in the talk? Because I suppose we need to fall in line with that, and how close is that being delivered, or is this we're talking about long term? Zoe,
yeah.
lovely.
I can answer that. I can answer that. There's a European care strategy. Not to put across, but I just know of it. There is a European care strategy, and if you look at it in some ways, it's because it's the EU 27. It's actually in some ways not as ambitious as an Irish sector would like it to be in some ways, because we're it has to be achievable for all countries, and across the EU we're generally in some ways one of the leaders in policy and provision for family carers specifically. So that's that answered out the question, and I'm sorry for cutting across, but Fiona, do you want to go on ahead and say whatever you're saying?
Yeah, like, and there's something around, do family carers want to be family carers? You know, like, or do they want the right support to support them, to support their siblings? Okay, so like, I suppose like we have like come up with an, you know, and over the past few weeks, we've seen in 2 days how our government can say, okay, family carers like don't have to be means tested anymore, just because of a silly statement one of our, you know, politicians have made. And I don't think family carers is the right way to go. I think disabled people, older people, younger people, they need support. Disabled children, you know, need the required support and need the right to an assessment of need, and that carry forward through their lifetime. And I don't think, families, like parents just need to be families. You know,
As
200
you said,
euro per
parents to
week.
be and wives to be wives and partners to be partners. Exactly as you said, that was a powerful statement. So thank you so much.
Yeah, and I know we're short of time, but this is really, really important. Disability allowance didn't come into the conversation when they were talking about carers allowance. Disability allowance is means tested. And if disabled people that work had access to disability allowance, they could pay for their own support and what they need to support themselves. And as you said, parents could be parents, sisters could be sisters, brothers could be brothers. Disabled people could do whatever they wanted. They could get a job, they could go here, there, everywhere without reliance on family members or, you know, that kind of dynamic. It would be like, I suppose, if you have an expectation of your non-disabled child, you expect them to reach milestones, to reach independence, to do what they want eventually. Well, disabled people inherently feel that as well. So inherently they want to reach those milestones. They want to reach the Maslow's hierarchy of needs to get self-actualization. Okay, I know I've taken up a lot of time, so
And the other thing, Zoe, is worth to mention that I would never hire my husband as my carer or supporter. I'd fire him. So I would. So yeah, and I'm a personal assistant user for 30 odd years, you know, and I've reached the benefits of it. But there are so many people out there that have not got access to that. And that's
Okay.
really fundamental.
So on that note, Fiona, about your husband, we will finish this little talk. So I just have to go on for time, but we could carry on for quite a while. I had thoughts again. I will hesitate to come back by email probably later on. But just to respect everyone's time, of people in the room, I know it's a very busy time of the year as well with Christmas, so we appreciate it. So thank you so much to our speakers, Fiona and Claire. Really, it was a great talk, and we're really, really happy to have you here. So we're going to go on to the next one. So it's Ellen Edmonds next. So Ellen Edmonds is a lecturer at the Technological University Dublin, and she'll be discussing about the built environment for family caregivers. So it's a very different type of topic, probably one we don't bump into enough. So as she does follow a bit from what you were saying, Claire, around the built environment and how that does impact caregivers or people living with disabilities. So it will kind of carry on onto now the environment side. Yeah, go ahead, Ellen Edmonds, and if you want to put your slides up as well. Thank you so much.
Hi, everyone. So as introduced, my name is Elaine Edmonds, and I am going to be looking at a very different topic today. This is probably not what you expect to see in a social policy context, but I come from the world of spatial policy. And so I'm going to be looking a little bit at, is the city a caring city? Is the country a caring country? And what has planning got to do with all of this and with a carer strategy? So a little bit about me to start. Why do I care? Mostly because I am a long-time carer. I've been a carer from a very young age for multiple members of my family, and we do use that language and identity within my family with the permission and support of the people in my family. That is their preferred language. I also provide them support. They have extra support needs, mobility issues, sensory issues. And I've been a carer since about the age of 12. And I saw, even before that, a huge impact on my life and my own ability to access the city, to have the experiences of childhood and teenage years, due to the accessibility issues we encountered as a family. whether that be around the mobility issues or sensory needs, or even just needing extra support to access areas. And in seeing that from a very young age, I wanted to change it. I'm sure a lot of us in this room have probably wanted to change the world, and that's how we ended up where we did today. But for me, I wanted to change the structures around me and the barriers I saw in life for my own abilities, for my family, etc. I'm now 15 years in planning practice. I have worked nationally and internationally for many clients, from Sports Ireland and the government down to individuals. I have masters in planning, urban design and regeneration, but I have in the last few years transferred into academia, and I focus in academia on diversity and in consultation and bringing people into planning. So let's start with, where are we with the current strategy? The current care strategy, even just at the very top, discussing the scope, acknowledges that there are issues that are more in the world of spatial planning and spatial policy than there are in social policy, in terms of housing, transport, and the labour market. These are three things that are all sort of governed through spatial policy more primarily than social policy. And there are three areas that any disability and care strategy should really be engaging with. However, when you go through the carer strategy, none of the goals or objectives actually deal with housing. Not one. So even though it is up top, right there in the scope, it is not then dealt with in a goal or objective. And in policy terms, that basically means it's toothless. The references to transport or the labour market don't actually reference any of the spatial qualities or the economic plans that actually govern these areas. And in the bodies involved, the department's responsible listing, there is no mention of the actual bodies that are involved in planning, whether that be the Department of the Environment, Housing, Local Government, and Heritage, as they now are. I have to relearn the acronym every few years. Or the transport authorities, the local authorities. So the social policy is not dealing with the spatial element. And we know from even just work done by Zoe that there is a significant geography of care, that actually your spatial location, along with all your other pieces of identity, influence your care, your ability to care, and influence the supports needs, vary how people experience their disabilities, what their barriers are from that social model. So trying to span the two worlds, where does planning policy come into this? Does it consider care? Sort of, and probably from the right perspective, because it largely considers care actually more from the point of view of how it disables people. So we have just analysing national policy, not getting deep into it because the entire world of spatial policy is vast. But in national policy alone, we have the consideration for age-friendly locations. So this is going to actually assist some people who have extra support needs in reducing those support needs and assist carers in supporting them. We have a national policy objective that local planning, housing, transport and leisure will be developed with a focus on meeting needs and opportunities of an ageing population. With respect to ageing communities and having them be a core part of strategies. Excellent news. So spatial policy is taking some account of reducing disabling barriers and accounting for our changing society. We also have a section in healthcare planning. So the spatial policy tries to deal with access to health services at all different levels, from acute right down to integrated community settings, considering mental health, disability, and services for older people altogether. And this all would be generally positive from the point of view of that intersectionality piece. If you're accessing one service location for multiple services, that should reduce barriers and support needs. But apart from that, at a national policy that is, if I remember correctly, it's 183 pages long, which is short by our policy standards, but long enough. Those are the only two references to care or to removing barriers that aren't to do with childcare, which, considering the percentage of the population who have extra support needs and the fact that becoming disabled by something is something that can happen to absolutely anyone. It's the one community anyone can join at any point in time. So we also know that it is an aging population. It's a population that likely a lot of people will join. So this probably isn't good enough from a spatial policy point of view either. And there's an entire lack of integration. The spatial policy is entirely silent, does not mention care policy at all. Doesn't mention disabled policy very much either, outside of the aging population. The caring policy is entirely silent on that spatial element, on the geography of care and how it influences. And it's not influential in those policy areas. So we have two very different silos of policy working at very different ways, very different levels. One of which is entirely silent on the spatial, and the other is very impactful but silent on the caring. So what is my big sort of ask or idea, or how would I look at integrating this into looking at a carers policy going forward or a carer strategy going forward? Really, it's that there's changes afoot in planning, and could they actually grow to include social policy? Could we create an integrated policy environment that accounts for both social and spatial policy? Well, we have an opportunity to, coming from my side. There is a current planning act that actually only got passed about 3 weeks ago. I haven't yet managed to read the full thing. It's 908 pages. Isn't it great? However, the big move that it makes is that it is creating a spatial policy hierarchy led by a long-term strategy on planning, economic and regional development, including funding, including employment, housing, and a lot of other parts. Why can this not also include social? The advantage of this is that it requires policy consistency for planning. We are going to have all policies in spatial planning be consistent and relevant to each other. It creates a method for identifying and funding services and projects, which is something that would be on that long-term basis. And it includes community consultation, which I think is something we really need to consider, particularly for social policy. The community consultation social policy, from what I have seen, is very much focused on getting the views of those working within the sector and so-called experts, rather than the experts of lived experience. Spatial policy has always, while not been great, been stronger on this. And therefore, there is probably learnings across the sectors. It would, however, have one big barrier, which is that it needs HSE alignment. Little bit of silence there. Little side, the HSE restructuring was meant to follow along the same lines as spatial governance restructuring happened in 2014. And that is actually under the Local Government Reform Act. However, when it came to the HSE restructuring recently, they completely ignored actually the legislative requirement for them to consider this, and reformed in a way that doesn't align spatially to the existing governance in other sectors, which I think is one of the big real barriers to this. In the meantime, That is one big ask. That is a very large ask to essentially reform public policy to create a uniform policy environment. And it doesn't have to be led by planning, but there is an opportunity with the planning changes recently to do that. But for now, what can we do about the geography of care and bringing the spatial into our care policy? What we can do is get involved in the spatial policy side. Get involved in planning when you have a chance. So this is my little sales pitch beyond the carer strategy, for people to consider how can your caring or how can your need for access and disabled supports and the reduction of barriers influence your geography? Well, we have consultations on plans every 6 years at every level, national, regional, and county level. And it is free and relatively easy online to both access and comment on these things and actually influence planning and spatial policy from the perspective of carers. And as planners, we need to hear more from every community and hopefully eventually create an integrated policy environment. Thank you.
Amazing, thank you, Elaine. So I'm a bit not surprised, but I did not hear about this consultation that happens every 6 years. So I'll be delighted if you don't mind if you just put it on the chat or even just send the link to Zoe to share with the group. I don't know if I'm the only one, but it's definitely something that I heard about, but didn't know it was a frequent measure. So great detail to have. Okay, so does anyone have any questions for Elaine about this talk? So it's effectively very different. So I've definitely seen a lot of research coming up around the link between emotion and place, and the emotion that it provides. So also around, I suppose, the big green space debate, where if you have like, green space close to your house 5 minutes away, you have a higher life expectancy or maybe better health outcomes. And I can see where it places, with the role of caregivers who do tend statistically to be more at home or more frequently at home than general Asians. So it's just, very complete to have this talk, Elaine. I can see Fiona has a hand up there as well. I'll leave you there.
Elaine, that was a really, really interesting presentation. I'm just wondering about universal design and universal design plus, and obviously AI and then assistive technology. And then where that can, and usually it can impact on what you're talking about and speaking and recommending.
We're seeing a move towards universal design being integrated. I think for it to be fully integrated, there's a number of issues. First of all, in terms of actually having design professionals who are qualified, interested, or even just experienced enough. And I think
or even care.
Well, we do have policy requirements to consider it. I personally have a little bit of an issue with the idea of universal design. I think that the world is so diverse that there is no such thing as a universally accessible design. And I deal with this in terms of even educating. There is no one way I can educate that is universally accessible. So sometimes I think it's a little bit of a red herring in itself to say, oh, well, this is done according to universal design principles, but that doesn't mean it's actually universally accessible. So I'm a little cautious on this reliance on universal design at the moment. I think it's going to become another generation's, sustainable development term. But we are seeing growth in an interest. We need more trained designers. We need more trained people to actually work in the sector, but also we need the sector to be more diverse, and so that the experience of people working in the sector can be reflected by the work of the sector. I know this sounds complicated. This is one of my things at the moment. The planning sort of community is quite white. The gender balance is pretty good, but it's generally white, middle class, able-bodied And that has an influence on the decisions made by planners. But I think step one is to get people involved in planning, consulting, doing consultations, to then grow an awareness of what you can do as a planner to then become a planner and change the system from within. Whole thing, I'm currently writing a doctoral proposal on it, so don't get me started.
Okay, so I just saw as well, Elaine, following this, just a quick comment by Brian. So Brian kindly shared in the older adults actually space, there is work happening in this area being led by the Department of Health and Department of Housing, local government and heritage. So there's a link there with around the projects of age-friendly homes, housing resources for our aging population. So just to complete what you've been mentioning there with just that special target, I suppose, on older adults. But thank you so much. Yeah, Brian.
I love that that's included, but my problem is that by including older people, we are missing out, again, that intersectionality piece. We're siloing who is, who needs support needs for what reason. Are we going to have a policy on older people, a policy on people with intellectual disabilities, a policy on mobility issues, a policy on, and then we're just ending up in policy overwhelm instead of creating a policy environment that says people have different abilities at all different ages and need different support needs. And this is what an accessible and lowered barrier support world looks like.
So,
Yeah.
I'm just wondering then, Elaine, it's about inclusion, for everybody, and taking away all the barriers and listening to what the barriers are and then deconstructing them.
Yeah. And that's an incredibly difficult thing to do in a world where, as humans, we like to fit things in neat little boxes, write policies about them, and then say that's done. That's not the world we actually, exist and live in. And particularly talk about Europe and the policy coming down from Europe. We are in an extremely centralized government environment, and different places deal with this at very different levels that allow for different levels of democratic power. It's all extremely complex. But in an Irish context, we need to stop just keeping on writing policies that conflict with each other in silos and create a unified environment where we all know what we're doing.
Okay, a lot of food for thoughts there. I think there is a lot of points of debate that can come out of that. So definitely we'll keep that in our mind. I suppose as well, it's a good introduction for us, for myself anyway, that's not familiar with this type of policy. It's a different angle totally, but also completes every, little group that we're all conversing. And then at the same time, just general people in the world needs to be concerned around this as well, because we're living in environments on a daily basis. So definitely a powerful talk. We need to think about all this together. I'll go on to the next talk, Elaine, if you don't mind. Just time, again, flying. So thank you so much, Elaine. It was fabulous. I actually just really have that topic in heart. I do see the power of it. So next we have Dr. Rosemary Daynes Kearney. So she's a researcher from the University of Limerick, and we'll talk about the available online resources for family caregivers. So it's a great and a timely manner conversation. It's something that really is, growing very quickly, the online resources. So it's just good to kind of touch base on that and see where we are. So Rosemary, please feel free to join.
Thank you very much. Thank you, Carmen. And thanks, Zoe, for inviting me to be here. I'm conscious it's the graveyard shift and everybody's probably getting a bit tired. So I'll try and keep it, entertaining somewhat for you, or engaging maybe is a better word. And I'm going to start by telling you just a little bit about my own story. 13 years ago, I was working away in a job that I really enjoyed, and I was pregnant with my first child. And then this happened, and I'm just going to hopefully share my screen. Nope, hang on. So by going into slideshow. So
yeah, we can see it there.
Hopefully you can see here this very handsome gentleman in the hat who you might recognize as beloved son of Ireland and Hollywood superstar Colin Farrell. And you can tell by the big happy head on me that I'm absolutely thrilled to meet him. But the reason that I met Colin Farrell is because this equally handsome little baby down here is my first son, Owen. And when Owen was born, he was taken from my arms and brought to the paediatric ICU in Crumlin Hospital with an undiagnosed cardiac condition. And he had surgery at 2 days old, 3 months old, and at 18 months old. And so I was thrown into the world of caring. And I remember being really worried about having to go back to work because he needed full-time care. And his cardiac nurse said to me, well, you know that you're a carer so that you can get support. And that was the first time it had really hit to me that I was a carer. And that was really ironic because my job at the time was as a support worker for a family care support program in Dublin in an organisation called Crosscare. So my full-time job was providing information and support to family carers. And yet I myself didn't identify as a carer. And that question of identity has come up in several different ways today. And this identity of a carer, whether you're a carer from a minority group, or from a traveller group, or from a kind of a dominant group, it really does impact on whether you do engage with supports or not. And that would have come up through my research. And at that time, I remember the National Carer Strategy coming out, and writing information kind of notices to break it down for the family carers that we were working with. And I think it's really important to remember the context of that time, 2012, it was recession. People were losing their pensions, they were losing their jobs, they were losing their homes. And so Liam talked about maybe a feeling of disappointment that it was cost neutral, and there was definitely that. But I think the spirit of the strategy was that it was an acknowledgement about the valuable roles of family carers within the community, but that there just wasn't money in the coffers to be able to provide funded supports for them. But that context really has changed, and we, as has been said in the recent election, the country is doing good. Financially, we're in a very good position. And so I'd be challenging any new strategy that would come out that it has to be fully funded. And I would agree with Kerry around that. And I think as well, before the recession, there was an impetus around bringing visibility to the role of carers in lots of different ways. And I think, with the recession, this inertia came in. And I, in fact, feel myself that the visibility of carers is, in fact, receding somewhat, and that we're maybe going backwards a little bit rather than forwards to bringing the full visibility there. So also my job at that time with the family carers, we looked at whether to roll out online support groups in recognition that many people were online. There was the advent of the smartphone, more and more people were online, and whether this was a place where we could add value to carers. But we never took it on because we didn't really know how to do it, and we were worried about causing harm rather than helping. And so I've just completed a PhD that has looked at this whole area, and I'm going to share just a small snippet of some of the findings on this. And then in the new year, I'll actually, as part of my postdoctoral work, will be maybe holding some more webinars to go into the findings in more detail. But what my research had found is that when people are coming, actually, before I go into this, I actually wanted to just do a little bit of live action research. So I'm going to do something terrible, which is just ask you to engage for a few minutes, if you don't mind, in the chat box, because we can just very briefly find out quite a lot. So just if you want to type into the chat box, or even just put up your hand, whether you yourself are online, so whether you've access to online, and I imagine we're going to get yes, because everybody here is online today. So even a Y is okay. We could take that one as maybe given. I can see that the Ys are coming in. So how many of you are involved in any kind of online group or community? So we've got more yeses coming in. So we can see here people are involved in some kind of online group. And then how many of you have engaged in that group to either get information from the group or to receive information from the group. So again, more yeses are coming in. And then how many of you are engaging in that group because it makes you feel good? You're getting something out of it in terms of emotions, emotional support or esteem, or it's generally making you feel good. And maybe you can actually get something tangible from the group. So maybe you've been able to swap clothes or swap equipment or something like that. Would that be an experience people have? No, so less there. And then how many of you would feel like these people who are in your online group or online community they're like friends to you? You may not have met them, you may not know who they are, but you feel a kind of a closeness to them and maybe call them like online friends. Or I'm in a Pearl Jam fan club and I always call them my Pearl Jam friends because we're talking about Pearl Jam. And so in that little exercise, we can see that these are some of the main findings that would have actually come out of my PhD around the types of support that people are getting there. And thank you for taking part in it. We know that online groups are popular. We know they've been around for a long time. We know that people get stuff out of them and that these can lead to positive health and well-being benefits. And we also know that there's some negative experiences as well. So that can be that people maybe experience negative comments or maybe trolling, or that there can be dominant members who take over a conversation, or that you can get bad information and so on. And so as part of the PhD, I came up with this quite complex framework that I'm not going to share with you, but I'm going to share with you a more simplified version of them. So hopefully Colin will disappear. Yep. So first of all, when people are going into online groups, they're looking for something. And actually what we found generally was that this was informational support. So there's something that's after happening to them in terms of their caring and they can't get the information. So they go on looking for informational support. And within that, then they take a decision that they're going to actively join this group. So a lot of the online groups are Facebook groups, but they can be forums as well. And you can post anonymously, but a lot of people would, sign up to become some sort of member of that group. Interestingly, what we found is that there's this period of observation. So some people would jump in and engage directly with the group, but a lot of people would observe what's going on. And they look at things like how safe the group is, how good is the privacy, and what's the tone of the group, and how is it moderated. And then by looking at that, they make a decision about whether they're going to actively engage or not. And what we actively engaging can be reading, so you continue to read, but also by posting, commenting, or maybe asking questions or putting up requests for support yourself. And we found that with engagement, people did experience social support. And the two areas that we looked at was social support, and what we found is that online support groups like the one that Care Alliance Ireland run have a very strong positive effect for breaking the social isolation that many carers report experiencing. We also looked at stress, and interestingly what we found is that there was a commonality of stress between carers who were in online support groups or not in online support groups, but that the group itself didn't directly impact on that level of stress. And so this points to me that the sources of stress are actually, as we've discussed here, things like structural supports and not having the right services available for the people that they're looking after and caring for and supporting. And then underlying all of this, we found that one of the psychosocial mechanisms that impacted on this was the level of identification. So if you identified as a family carer, you were more likely to engage in online supports. And that within the group, if that level of social identity was stronger, you were more likely to actively engage, like by posting or commenting, and that you were also more likely to receive support from the group. So within this indicates that there's a number of areas, if we were considering from a strategy or a policy perspective, actions that need to be taken to support practitioners. and also carers themselves. So there's a big piece around education, and I think this touches into a lot of what the previous speakers have talked about: identification of minority groups. How do you know that you're a carer? The language that is used. Do we even have to use the term carer? Is there a more expansive definition that can be used to help people identify that they maybe fall within this category that's that the support is being offered to? It's also about how the groups are run. So the moderation, having really strong, trained, either peer or professional moderators, whether they were volunteers or whether they were a paid part of the organisation, was really, really important for creating both the sense of safety in the group, but also that sense of identity. And so we see here funding is necessary in order to enable organisations to run these groups, and also training for the moderators around maybe some of these psychological mechanisms that are underpinning these groups that make them more successful for people. So where do these fit within a policy perspective? So I'm assuming everybody has heard here of Sláinte Care. This is our big overarching healthcare policy. And so if we're looking at where online support groups might fit, there's two real avenues where I can see them. And the first is, sorry, I just noticed a typo on my slide. The first is this avenue of digital or telehealth. And there is a telehealth roadmap, and that's where we're using things like virtual care wards, or this Silver Cloud CBT program that's there to support people with low-level mental health challenges. And I was one of the patient representatives in developing the roadmap that was published last year in 2023. And online support groups are mentioned in it, but they are mentioned from this perspective of self-directed online supports, as opposed to the type of online support group that Care Alliance Ireland are looking at. The second avenue are community supports and the social prescribing, which is much more community-based. It's primarily in mental health at the moment. There is a framework in place, which is what one of the lines is meant to say here. And this is really about supporting people within the community by developing peer-to-peer supports. And there's a lady called Della Morsley. She's a researcher from the US, and she's a Black feminist researcher. And when she was looking at how to support communities, Black female communities in America, she spoke about what's the aim of doing it, and what do we want to get out of them? And she looked at the difference between coping and healing. And I think this is a really powerful philosophical question that we need to ask ourselves in terms of developing a policy or a strategy. And Kerry has touched on it, and Claire and Fiona have touched on it in terms of supporting people with disabilities. What do we want our society to be? Do we want it to be a caring society? What does that mean? And how can we achieve that? And this is really then, if we're looking at the digital supports, we're looking at coping, and coping is individualistic. You're going out there yourself, and you're getting, you're engaging in these self-directed online supports. But there's nobody there with you. It's your own personal individual journey. And at times that might be the most appropriate pathway to go through. In my experience of being a carer, and my caring journey has continued from my son. I have my second son who's autistic. My third son, we're getting assessed next week for autism. And my husband in 2020 had a mental health breakdown, which has led him to have ongoing mental health and physical health challenges as well. So caring has really come through my whole life. And at one stage, I really focused on this coping side of it. But what I really realized is it's all, for me, and I think where I'd love to see our society go, it's about healing. And healing is collective. It's about community. It's about taking collective action. And Kerry really explained it much more eloquently than I have in terms of maybe steps that are needed to consider within that. And also, as Claire and Fiona touched upon, it's about understanding power imbalances and language, and the power of language as well. I'm bringing Zoe's in about this intersectionality that we have. It's about these bigger conversations. And so I don't think we have an either or in terms of whether it's disability or care, but it's about both. All conversations need to happen, and we need action on all sides. And so I'm also coming to the conclusion that it's not about necessarily a carer's strategy, because my own experience of being a carer over the last 13 years is that words really mean nothing. I really want action. And I have lived as a practitioner where our care support program was shut down because the funding wasn't available, and the heartbreak of closing down a service that was 25 years old. I was made redundant because the funding wasn't available. I've lived going through the social welfare system, going through the means test, and that fear of that brown paper envelope and what it holds. I've lived having my social welfare payments cut without notice and having to advocate to get them back with no money to buy food. I've lived having to go through the broken system where my son is still waiting for his public assessment of need. And we're in the lucky position that we've been able to privately pay for the supports and services that he needs. So if you're to ask me what do we need, I'm going to quote from Jerry Maguire, show me the money. If we put all of us together in this room for a day, the knowledge and experience that's there, I know we could write out a really good strategy. And in another day, we could probably write a really powerful implementation plan. And if you put us together for a week, we'd probably write a really good piece of legislation that would underpin everything. But my own experience, and I have worked a lot with the HSE in different roles about legislation and implementation, is there has to be will, there has to be people driving it from the top level down, and it has to be a priority to the people in decision-making power. It needs to be on a HSE service plan, and there needs to be a budget beside it. And so I would hate to bring people into a space where we ask them and take of their time to develop a new strategy when what will we have to show for it? And I know that this government is committed that there's going to be a revised care strategy, but the previous programme for government did the same as well, and yet here we are. So I don't want to end on a downer. I think this has been a really interesting and really worthwhile conversation, and it's been really powerful to hear everybody's perspectives. And I'm very happy to take any questions from anyone there.
Thank you so much, Rosemary. Sorry, I muted myself. It was really, really interesting. Online resources, again, continue to grow. To see that policy perspective is key moving forwards. So does anyone have any questions? We have probably like 1 minute left. We promised to finish at past. So we have time for one question if someone has any thoughts, comments for Rosemary. Please, Fiona, go ahead. You're on mute, Fiona. Careful. It always happens at the end of session.
Okay, I'm sorry. Thank you. Okay, that always happens. I suppose it's a really powerful presentation. And I suppose the disability community is very worried about using individual stories in that, like, and our sort of media just sucks it up and it doesn't work. And it creates charitable narratives and non-governmental forum, and it's around collective, and like you said, Rosemary, like I'm sure around this table, virtual table, we could write very good policy documents, you know, that would work very well for everyone in this virtual room today. And it's around collectively using our experience to do that. And yeah, it's just a comment, not a question. But thank you.
Thanks, Fiona.
It's a beautiful comment anyway. Fiona, you complete me very well when I'm sharing, so I wouldn't mind having you each time during sessions. Okay, well, thank you so much, everyone. Just a special thank you, now that I have the time, just quickly to all the speakers that came in the room for doing that effort, to having so much angles as well. It really was special. I think, I hope everyone feels the same here, but there's a lot of learning, a lot of thoughts. I think we're probably a bit tired at this time, maybe just to digest everything. And to continue that conversation is key. And this is what we hope by organizing these research seminars. So a special thank you as well to Zoe, Amy, even the Chief Executive Officer, Liam O'Sullivan. There's a lot of hidden work there behind. So really thank you for organizing this for all the carers that work with us, and to all the general agents and caregivers, or, just professionals connecting today to give you your time. And we wish you, from, all the CAI group, all the, a great holiday season. Do take it to rest. And well done for taking this time just to breathe and, get that learning as well. It's nice. We need to stay updated on things. So we're looking forward to collaborating further, and connecting for these chats as well that are a bit informal, and it's nice as well for growth to have those chats and also that time. So yeah, thank you so much. Does anyone have any thoughts, comments just before we end, or are we good for now? Zoe, yes,
yeah,
please.
I just want to say thank you, Carmen, for chairing the day. Very much appreciated. And like that, if anybody has any comments or anything extra they want to get in touch with me, that's my job. I'm the policy officer here, so please do get in touch with me if there's anything coming up, and I'm sure the other speakers would be happy to chat as well. And Claire, do you want to say something there?
Yeah, just thanks for having us. And also, if you are a disabled person or know a disabled person that would be interested in joining the collective of disabled people, because as Rosemary said, it's very nice to have a tribe and people to connect with that share similar experiences. You can contact ILMI .ie, or I'm sure Zoe will send on her details. So thank you.
Thank you so much, everyone. And just a little side note, we just created our LinkedIn. So if anyone wants to follow the CAI LinkedIn, feel free to do so. It's similar to the website. We're trying to make it just more accessible for everyone to see all the updates, so through different medias. So yeah, thank you so much, everyone. Have a great evening. Take care. Enjoy your little break season. I hope you do get a break. Bye-bye. See you soon.
Thanks, everybody.